What's up, everybody? Dr. Rossi, shrinksandSneakers.com. So today I'm going to cover the much anticipated and much requested topic of bipolar disorder. So I'm going to start with the basics like an introduction, statistics, epidemiology, some of the important things that anyone with bipolar disorder or anyone who treats bipolar disorder should know about this disorder prior to moving on to how we evaluate a patient in the depressed phase and how do we evaluate a patient in the manic phase to determine what the best course of treatment is going to be. With that said, let's crack right into the introduction and get this video going. So bipolar disorder, most of you probably know, especially if you're dealing with the disorder and or treating the disorder, that is characterized by something called episodes of mania or hypomania. So mania and hypomania, I'm going to explain later on exactly what they are and how we diagnose them. But for now, let's just say that that's what really characterizes or separates bipolar disorder from other psychiatric disorders. Also important, when you're thinking about severe mental illness, this is one of the big three. And when I think about the big three severe mental illnesses, I think about bipolar disorder, I think about schizoaffective disorder, and then finally schizophrenia. All three of those tend to be some of the more challenging disorders to treat, as well as some of the more challenging disorders to diagnose, and we'll talk about that here with bipolar. So the person with bipolar disorder is going to have an episode of mania or hypomania, right? And the difference between these two is often in severity of symptoms and duration of symptoms. So what separates bipolar 1 and bipolar 2 is severity and duration. Another thing that I like to point out is that people with bipolar 2 disorder spend primarily their time in the depressed phase. They actually spend very little, somewhere around 4% of their time in hypomania. So bipolar 2 often comes with primarily depression. Recent estimates suggest that between 1% and 2.5% of the general population are affected by this disorder. So somewhere between 1 and 2.5%, similar to things like schizophrenia, which are about 1%. So bipolar disorder is also associated with significant morbidity and mortality. And why do I say mortality? It's because more than 30% of patients with bipolar disorder attempt suicide in their lifetime. So 30% of the patients I see are going to at some point attempt suicide during their lifetime. That is extremely significant and extremely concerning for any psychiatrist or patient with this disorder, being very mindful of those depressed periods and the risk for suicide. The diagnosis is often challenging. And why is bipolar diagnosis challenging? It's because patients can present vastly different depending on what type of symptoms they're having and what phase of the disorder they're in. Are they in a manic or hypomanic state, or are they in a depressed state? Now, depending on where they fall in that category, in that spectrum, you will find that it can be often difficult. And majority of patients are going to spend more time depressed than they are manic or hypomanic. Okay, so let's talk some statistics or epidemiology. I think this is important actually for patients to know, as well as for psychiatrists, obviously, because it helps to kind of put into perspective when you can expect to start to see symptoms, when you should be on the lookout for this disorder developing, and when it might not be appropriate to diagnose this disorder right away, and you may want to look for other potential medical causes of mania or hypomania. So, the lifetime prevalence I had already talked about of bipolar 1 and bipolar 2 is somewhere around like 1% when you combine the two. So on par with things like schizophrenia, which is around 1%. Important point, prevalence rates between males and females are similar for both bipolar 1 and bipolar 2. So this is different than major depressive disorder, where we see a female predominance of major depressive disorder. So being mindful that both males and females are approximately equal in terms of prevalence rates. The average age of onset is actually a little bit different between bipolar 1 and bipolar 2, but when we average those out on a whole, it's 20 years of age. So the onset is relatively early in someone's life, and it's also occurring at a relatively critical periods when the person is graduating high school and probably starting or near completing college. The mean age for bipolar 1 disorder for manic episode, is 18 years of age, and the mean age for bipolar 2 is 20. So it's between 18 and 20 you want to start to be mindful of looking out for this disorder developing. Now, up to 65% of patients with bipolar disorder have their first mood episode before the age of 25. So if a person doesn't have a mood episode, you're not going to say it couldn't happen after the age of 25. Obviously, it can, but you want to be looking out for it much earlier on. Again, this signals to us that this disease tends to develop early in life, and we want to be mindful of screening for it and making sure that we're identifying those people who meet criteria for either bipolar 1 or bipolar 2. Now, I said you may not want to diagnose this disorder in certain instances, and you want to always think about someone who comes in their 4th decade or later in life. So if they're in their 4th decade or they're older and they come in with hypomania or mania, I think you want to rule out all types of medical or medication causes or substance use causes of potential mania or hypomania, because it's very rare for someone to develop new onset bipolar disorder after the 4th decade of life. Doesn't mean it can't happen, doesn't mean it doesn't happen, just means it's very unlikely, and you're going to want to rule out other things before making this diagnosis. The prevalence of bipolar disorder is actually similar across racial groups, so we don't see a big difference between racial disparities in terms of who develops this disorder. Patients with bipolar disorder often have comorbid substance use, and I kind of mentioned that here a little bit prior to talking about it, but it's very, very common. Up to 60% of patients with bipolar disorder will have some type of substance use issue, and the most common one, as you might guess, is alcohol, because it's readily available in most places in the United States as well as most other countries. So alcohol is your primary substance of choice, although it doesn't mean patients with bipolar don't also use things like cocaine or amphetamines or opiates. All of those things are also possibilities, but it's a significant risk in terms of patients with bipolar disorder and something you want to be screening for. Other common things to screen for and look out for with bipolar are comorbid anxiety disorders, comorbid ADHD, and comorbid eating disorders to round things. So I want to talk in this section about the subtypes of bipolar disorder, because there's 2 different types that we're talking about here, bipolar 1, bipolar 2, and then of course there's some other stuff that we can throw in there like mixed episodes, cyclothymia, rapid cycling, etc. So to start off though, I want to clarify a few things. The diagnosis of bipolar 1 disorder requires 1 lifetime episode of mania. So the person has to have a lifetime episode of mania in order to qualify for bipolar 1. A big misconception amongst the general population is that the person also has to have a depressive episode, a major depressive episode to qualify. That is not true. Somebody with bipolar 1 disorder could have just what we call the pure manic type or pure mania, where they actually don't have depressive episodes. So it's the mania that really helps us to qualify for a diagnosis of bipolar 1 disorder, whereas the depressive episodes often occur with bipolar 1, but are not 100% required to make the diagnosis. Bipolar 2, though, is a little bit different, because bipolar 2 requires the person have at least 1 lifetime episode of hypomania, but they also have to have at least 1 lifetime episode of major depression. So they have to have the depressive episode and the hypomania to make it a diagnosis of bipolar 2. Important distinction between these 2 subtypes. Now, mania, I said, is distinguished from hypomania mainly by severity of impairment caused by the symptoms, as well as the length of time of the symptoms. And I'm going to talk more about that in a little bit. But suffice for now to say that severity of impairment means things like hospitalization, inability to work, inability to care for your children, inability to care for yourself, right? All of those things can happen with mania, and again are more likely with mania rather than hypomania. Sometimes patients with hypomania actually become very productive during those hypomanic phases, and again they enjoy those phases because they're doing very well and feeling very good. The other point I had mentioned briefly was this idea of rapid cycling bipolar disorder. So rapid cycling bipolar disorder requires the 1 lifetime manic episode and a history of 4 episodes of depression, mania, or hypomania within a single year. So again, it could be depression, mania, hypomania, but you have to have 4 or more episodes within a single year, and that's what they mean by, again, it's rapidly cycling between depression, mania, hypomania, etc. So rapid cycling is another subtype to be mindful of. I'm going to touch briefly on the genetic impact, and we know that all of these psychiatric disorders are most likely multifactorial, and actually they're also what we would call polygenetic, meaning that there's not a single gene. We're unlikely to identify the so-called bipolar gene. We're not going to probably find that anytime soon, but there's going to be multiple genes that are going to interact with both the environment as well, epigenetic factors, that are going to contribute to somebody's risk factors for developing bipolar disorder. And if you've followed any of the typical studies in mental health, they're going to always look at twin studies. And you might ask, why are they looking at twin studies? And that's because we can do a lot of interesting things with twin studies. First of all, identical twins, or what we would call monozygotic twins, those twins are going to share the exact same genetics. And why is that helpful? Because sometimes what we see is in adoption studies, twins are separated at birth, right? One goes to one family, one goes to another family. So this opens up a whole line of research where we can see not only what the genetic impact is of the disorder, but we can also see how environment plays a role in that process as well. So basically, we have both genetic and environmental factors we can look at. But the point I want to make here is just that there's a significant genetic impact associated with bipolar disorder, the development of bipolar disorder. And what we see is concordance rates with identical twins being as high as 60 to 70%. So again, indicating a significant genetic impact. And the concordance rates between dizygotic twins, also known as fraternal twins, is between 20 and 30%. And that kind of makes sense because fraternal twins are no different than siblings, basically. So they don't share the same genetics or anything like that. So the course of the illness. This is a point of some controversy, but I want to make a few points here. And this might help to clarify why, psychiatrists and other mental health professionals generally recommend that somebody with severe mental illness, bipolar, schizophrenia, schizoaffective disorder, remain connected with treatment, even in those periods when they're doing well and they don't have any symptoms. So let's see if we can help you guys understand this a little bit and clarify some of these things. Generally speaking, bipolar disorder is a chronic disease, and it has a natural history that is both highly recurrent and progressive over time. So two other important points. So this is a chronic disorder that recurs often and progresses over time. And that's just been well documented within the literature. We've been looking at these disorders for a long period of time at this point and have well established information on the course of the illness. A single manic episode confers a near certainty that there's going to be future manic or depressive episodes. So again, this sounds a little ridiculous in the sense that we're saying it's almost certain that you're likely to become depressed or manic at some other point in your life if you've had a single manic episode. But that's again what we see. And it's highly likely for that person to develop either a depressed episode or a manic episode in the future. We can almost guarantee it. And sometimes these things are predictable as well. If someone was having a manic episode, they're likely to have a depressed episode subsequently, and vice versa. So we can sort of think about it from that perspective. The vulnerability to episodes actually increases as the number of episodes increases. And again, this makes sense because if we think about it, every one of these episodes is sort of an insult to the brain, right? And we think with bipolar disorder, it has to do with what we call excitotoxicity. So too much activity, too much excitement in the brain leads to damage and neuronal tissue loss, right? Neuronal cell loss and death because they're becoming toxic due to the excitation. However, you can see why the more episodes you have then, the more tissue you're losing, the more impact it's actually having, the more neurons you're damaging in your brain. So it's important that we know that more episodes lead to increased risk. And also there's this idea of what's called a kindling effect. And kindling comes from the idea of like a campfire kindling. It's always sort of like a low level burning, but as time goes on and as things progress, you could start to see a roaring flame, right? So this is the idea that it's always kind of festering under the surface, never quite fully out of our mind and never quite fully treated. Adults with early onset bipolar disorder are more likely to have a severe course. So this is very important too, and this is kind of a general rule of thumb in psychiatric conditions and psychiatric treatment, is that the earlier the age of onset, the more severe the symptoms will be, and the more episodes the person is likely to have over the course of their life. So again, severity increases with early onset. Depressive episodes actually can regress or go away on their own, right? So a patient who has a depressed episode, if you just leave it untreated, you do nothing about it, it will generally resolve somewhere within 6 to 12 months. So depression untreated resolves in 6 to 12 months. And the same thing can be said actually about manic episodes. Manic episodes untreated will last somewhere between 3 and 6 months. Now this creates a complication for anybody who's treating these disorders, because you may be switching medications and doing different things, and then suddenly the patient comes back and they're fine, and you're like, well, we must have got the medication right, we must have done something correct here. But the reality is that it could just be the natural course of the illness. And the natural course of the illness, again, indicates that approximately 6 to 12 months after someone starts becoming depressed, they are likely to, the episode's likely to remit spontaneously without any treatment over that period of time. And the same thing for mania, 3 to 6 months if untreated. However, the importance of treatment remains the same. It reduces the number of episodes, and even if someone does have an episode of depression or an episode of mania or hypomania, the treatment allows for less severity of those episodes. So the episodes become less severe, which is also important. I'm actually going to stop the video here because I think that's enough information for one video. In subsequent videos, I'm going to talk about how we evaluate a patient in the depressed phase, and then of course how we evaluate someone in the manic phase. And I'll go over all of the important criteria for diagnosis and what you want to be on the lookout for. So if you like the videos, if you appreciate what we're doing, please like and subscribe to the channel. It really does help me to keep making these videos for you.